just not enough. I'm returning from Asia Dengue Summit from Philippines. I've come straight over here. My learning, which I've seen across the trends emerging from real world, that the immediate immunity which is occurring after immunity, as per the real world trends from Brazil, it's cellular immunity which is giving protection as early as 7 days. Humoral immunity might take around 28 to 30 days to manifest itself. That is why at all three levels, innate, cellular as well as humoral protection is imminent. See, we need to understand that this vaccine has taken more than 70 years, so there were challenges. So our experiences with earlier vaccines in terms of neutralizing antibodies, it's just not sufficient. We need an extra layer, we need a multi-layered protection in terms of innate, humoral as well as cell-mediated in terms of CD4 plus, in terms of CD8 plus T cell responses, along with type-specific NS1 antibodies. So not only the quantity of antibodies is important, but the quality of antibodies. So what are those qualitative aspects? Those could be affinity, avidity, affinity maturation, complement fixation. All these were taken care of. So we did not restrict ourselves to neutralizing antibodies. We went into the antibody affinity, avidity, affinity maturation as well as complement fixation too. As far as NS1 protection, I have already highlighted, you need a broad homotypic NS1 protection which prevents against severe disease. Prevention of severity is important because NS1 protection is categorical in terms of dengue prevention. And even in these cases of patients who have impaired T cell immunity, we've seen that even after vaccination, dengue virus clearance is not happening because their T cells are not functioning. Any comments so far, Dr. Garg and Dr. Kukreja, on this? So far.
Even if the patient gets the infection, and in that situation, if the capillary leak doesn't occur, he's really protected. He won't go into severe disease. That's one thing, very important. And T cell immunity giving the patient protection quite early after vaccination. That's another very interesting point. And
what I can add is that as the backbone is dengue 2, so we are seeing a better response in seropositives for all, but even in seronegative, the best response is coming against dengue 2 because the backbone is that vaccine and other proteins are added to that through chimeric mechanism. So we are the most common serotype is dengue 2. That is why that backbone has been chosen, which is showing good results both in seropositives, definitely, as well as in seronegative.
Both are live attenuated vaccines.
Yeah. So with dengue, actually, it is only live vaccines which have thrived. The inactivated approach has actually failed. GSK was making one, it could not go further. So let's come to the efficacy endpoints. Yes?
Approved in 40 countries.
Approved in 40 countries. I'll come to the last slide, but Vietnam, Malaysia, Thailand, Indonesia, all are using it. It features in the National Immunization Program of Brazil and Argentina. It features in the State Immunization Program of Indonesia. More than 13 million doses of vaccines have been given across the world. We are trying to get a regulatory status. We are having a meeting with DCGIs maybe by 2026. It all depends upon DCGI. And yes, it is a WHO pre-qualified vaccine, last point. So now let me take you back to the trial results. In terms of the primary endpoint was vaccine efficacy against virologically confirmed dengue. Against every case, serotype specific RT-PCR was done. RT-PCR is the gold standard for dengue detection, we all know that. So vaccine efficacy against VCD was around 80.2% at the end of 12 months. Primary endpoint was achieved. Secondary endpoint was vaccine efficacy against hospitalized VCD. Virologically confirmed dengue, which is causing hospitalization, was around 90.4% at the end of 18 months. This is important because for a disease like dengue, which comes in epidemics and which can overwhelm the healthcare systems, reduction of hospitalization would be a good endpoint in terms of public health and in terms of office practice as well. Okay. So this cumulative vaccine efficacy persisted from 12 months to 18 months. Every year we had a publication. At the end of 4.5 years, it was around 61.2%. and it was seen in both seropositive and seronegatives. When we extrapolated that to around 1 lakh cases, we saw the vaccine was preventing around 5,000 cases in seropositives and 4,400 cases in seronegatives. So you can see this. Now this is the data for hospitalization. From 90% at the end of 18 months, it was still persisting to 84.1%. So 84.1% protection against hospitalization at the end of almost 5 years, and as you can see from this Kaplan-Meier statistical curve, there's early separation, this is sustained separation, and these graphs are not dipping. They are not dipping means the protection was still ongoing, though we terminated the study at the end of 4.5 years because our target was achieved. So when you extrapolate that to 1 lakh cases, it is preventing exactly 1780 cases both in seropositives and seronegatives. So statistical modeling shows that its efficacy against hospitalization in seropositives and seronegatives has been same. Not similar, but same. Okay. Now there have been some questions about DENVI 3 and 4. So we had 8 endpoints. DENVI in seropositives, DENVI 1, 2, 3 and 4. In seronegatives, DENVI 1, 2, 3 and 4. 6 out of the 8 endpoints were achieved. What happens in DENVI 3 and 4 seronegatives, as you can see in these circles, the sample size itself was so low. This is the seropositive, efficacy was positive. DENVI 1, DENVI 2, DENVI 3 and DENVI 4, there were just 17 cases of baseline seronegatives and just 3 cases of DENVI 4. So you can, that it is not possible to make any comment. So this is a challenge, The serocirculation of DENVI 1 and 2 has been the highest, and that was the trend which was seen in the trials for 5 years across 8 countries. So, and that is the only comment that, since DENVI 3 and 4, the number of cases was so low, it is not possible to make any interpretation, but there were no safety signals, there was no concerns with regards to safety on this DENVI 3 and 4. So this is what. So any comments so far, Dr. Kukreja and Dr. Girk, on the data so far?
Let's have questions from the audience. That's better than.
Okay, we have.
I say it's quite clear from your slides. What do you want to say?
Sir, really, it's a order of the day where we are getting dengue. It is not an endemic, it comes as epidemic. Even I can say pandemic to India, wherever it occurs, one part of it. My question is, since there are 4 types, even the vaccines are in, we are not been experienced, frankly saying we are not used that, though companies are developing what sir is telling. My question, suppose a patient gets one type, because he can get a recurrence, will he be completely protected if he gets the disease, say dengue 1 serotype? The next time we are not sure whether which type he is going to get. Whether he will be 100% protective of dengue serotype 1. As you said, dengue serotype 2 is the commonest one among this. But what's your
You're talking
comments?
about vaccinated, non-vaccinated?
Non-vaccinated. Sir.
Non-vaccinated.
And a vaccine is, it is a still, since it's a pandemic, it is beyond our reach.
Let's talk about the disease first. So you got dengue 1 infection and you have a repeat dengue 1 infection maybe after 2 years. You are completely protected. You may have a mild disease, but you won't have any problems. Now the problem is you had 1 infection and after a few years you tend to have dengue 2. Then the patient gets into trouble. The reason is it goes into, chances are it can go into ADE. Now in simpler words, what is ADE? ADE means the antibodies were formed against 1. Now the infection 2 has occurred, dengue 2. Now antibodies against 2 will be there, but only to some non-dormant type of antigens. But the dominant antigen of 2 is different from dominant 1. And this phenomena is known as original antigenic sin. Means once the body knows to make antibodies against one serotype, even if the infection has come 2, it will make antibodies against that serotype only. So what happens? These are low affinity antibodies. They get attached to this new virus, means 2, and they get attached to FC receptor. It is engulfed into the your monocytes, macrophages and all that. And inside they are not killed. Normally they are killed. They are not killed, so it goes on replicating and cause more breakage of these cells, leading to a lot of cytokine response and leading to a lot of severe disease. So that is the reason whenever you get a secondary infection with dengue with another serotype, then there's a huge problem. That's why the reason the children normally at the age of 10, 12, when they get admitted, usually they are seropositive and they get another infection and that leads to a lot of havoc. And many times you find in one season, there's not many cases, but dengue is there. The patient is not becoming serious. So most possibly the serotype is same as it was last time.
Thank you so much, sir. Only for the test.
So the corollary to the question is that if a patient has got Ven dengue, still he needs the vaccination because he may be positive only for that. He remains susceptible, and not only susceptible, severe disease against the others. So the vaccination has to be given in that individual also.
So we have to consider dengue as a 4 types of diseases. It has to be taken that way. So that's it.
No, exactly. I think you are very relevant in saying that dengue is 4 types of diseases because the structural and genetic differences between dengue 1, 2 and 3 are huge. So they are technically considered as separate species, and that was a challenge in vaccine development, that it may be considered as a 4-in-1 or a combination vaccine rather than a single vaccine. And just to add another aspect, whenever a natural infection is occurring, it could be monotypic, it could be multitypic. But with a vaccine infection, after